Irritable bowel syndrome. Irritable bowel syndrome, also known as IBS, is understood as a functional gastrointestinal disorder, often characterized as recurrent symptoms that relate to an individual's bowel habits. Patients with IBS commonly experience abdominal pain and discomfort, as well as a change in their bowel patterns. There currently remains no concrete disease process of IBS. However, there is a lot of literature that currently discusses the important relationship between the brain-gut axis. The brain-gut axis is essentially a complicated connection between the central nervous system and the gastrointestinal system. It can be influenced by hormones, microorganisms, immune cells, and of course, signaling from the autonomic nervous system. There are currently 4 different subtypes of IBS. There's predominantly constipation, predominantly diarrhea, and those who experience predominantly mixed bowel habits, such as constipation and diarrhea. And there's emerging evidence to discuss a 4th subtype known as unclassified IBS for those that are experiencing more of those functional upper GI symptoms, mucus in their stool, as well as kind of just like fatigue and lethargy. It's a little bit more of a generalized category. So, according to the Rome 4 criteria, the official diagnosis for IBS must include recurrent abdominal pain for at least 1 day per week over the course of 3 consecutive months, as well as 2 out of 3 of these different factors. So the first one is discomfort related to defecation, change in overall stool frequency, as well as change in the overall stool appearance and or form. So, although the overall pathology of IBS is not entirely understood at this time, the literature is continuing to highlight that common theme regarding the brain-gut axis relationship. There's numerous reasons why disruptions can occur within the brain-gut axis. The normal patterns of contractions within the peristalsis of the colon can be disrupted. These changes can lead to changes within the movement of the bowel's contents. Changes in motility can either be increased or decreased. So to better understand that gut-brain axis and its relationship with IBS, let's refer to the example where an individual may be experiencing heightened levels of stress or even heightened levels of depression in their daily life. These experiences can send signals from the parasympathetic nervous system or the sympathetic nervous system along that gut-brain axis, and you can see changes within the bowels relating to these feelings. So somebody experiencing anger or anxiety may experience disruptions within their motility that is represented as decreased motility, and you can see it as constipation. Whereas somebody experiencing more anger, more anxiety, that can increase your motility and cause symptoms like diarrhea. So IBS does have multiple layers. We have established at this point that, there is a pretty strong correlation between that gut-brain axis and changes within the gut's overall motility, causing the symptoms that patients typically expect or experience. So kind of back to what we were saying before, when people experience acute or chronic stress, there can be direct changes within the colon that leads to different contraction patterns. That brain-gut axis has the autonomic nervous system, is dependent on the autonomic nervous system, and the autonomic nervous system produces hormones such as corticotropin releasing factors or serotonin, which can also impede the normal gut function by increasing or decreasing the gut motility. Additionally, patients with IBS are also thought to experience visceral hypersensitivity, which can cause them to become more aware of those different sensations regarding contraction patterns within the smooth muscle of their colon. The concept of this increased visceral sensitivity in IBS patients is not quite understood. However, it's likely related to that gut-brain axis relationship, but it can lead these patients likely to be experiencing more pain because their tolerance of pain is lowered and they are experiencing that discomfort in their colon. Another thing I want to mention is gastrointestinal disturbances within that gut microbiome balance can also influence the gut-brain axis, as these disruptions can also cause changes in motility. Individuals with IBS symptoms have developed after infectious processes of the gastrointestinal system. So, in respect to those psychosocial factors, individuals with increased life stressors, or not just genuinely feeling themselves because they have a lot of anxiety, those people are more susceptible based on their immune function or their overall immunity to experience post-infectious IBS, especially if antibiotics were introduced during their treatment of care. So, food intolerance is the last thing I want to mention, as it is one of the most common influences in patients who experience IBS, specifically FODMAP foods. So, fermentable oligosaccharides, disaccharides, monosaccharides, these are typically the guiltiest culprits. And it's understood that these are the guiltiest culprits due to the fermentation and osmotic properties that can highly influence the motility of the gut. Um, and lastly, I just wanted to mention that gut bacteria is directly responsible for creating hormones in our body. So that just continues to demonstrate that really important relationship between diet and overall emotional well-being and just how interconnected that they are. So the etiology of IBS, again, as previously noted, the exact cause is not entirely understood at this time, but there is an overall focus in managing and understanding triggers and supporting the symptoms that follow. It is essential to support the patient through a gastrointestinal approach, but also to prioritize their psychosocial challenges as well. Interestingly, almost half of the patients who seek help for symptoms with IBS have underlying depression, anxiety, or somatization. Risk factors for IBS, being female. Females are Female incidences of IBS are nearly doubled compared to males, and the typical onset of these symptoms are between late adolescence and early adulthood. It's interesting that it's more common in females because the evidence also continues to demonstrate that there are higher rates of anxiety and depression in females as well. So it's difficult to say which comes first, right? The emotional dysregulation or the IBS, as these symptoms of IBS can also cause emotional distress. But prospective cohort studies have shown a direct relationship between patients navigating anxiety and depression and IBS symptoms. And again, as previously mentioned, overall immunity levels, such as individuals living in those chronic states of stress, or those with gastrointestinal infections, especially individuals who have disrupted their gut microbiome because they've had to take antibiotics to help with their treatment plan, are at very high risk for IBS. So patients with IBS may complain of primarily abdominal pain, discomfort, especially approximately 2 hours after eating. These symptoms will also include the urgency to poop, diarrhea, feelings of constipation, bloating, gas. In the earlier stages of IBS, these patients may complain of some mild pain. However, in later stages, more severe cases, this pain can actually be pretty debilitating. Individuals may also experience GI complaints in the upper areas of the GI function, so like dyspepsia, nausea, vomiting, mucus in their stool. It's also important at this time to gather subjective information about the patient's psychosocial well-being. You can inquire about family or social history, anything that highlights mental health challenges or just what their overall mental health well-being is at this time or has been in the past can really help provide more insight into supporting a diagnosis of IBS, especially anxiety and depression, as these are the most common psychosocial experiences that concur with IBS. Objective data, during your physical assessment, it might actually be a pretty normal overall physical assessment of the patient. However, you may appreciate as the clinician some tenderness when you're palpating, particularly above the belly button or the umbilicus and that epigastric area. If you do perform a digital rectal examination when you're still trying to gather the evidence, the examination will be normal, but the patient may experience or express some tenderness. The key difference, though, is that these patients aren't going to be experiencing fevers, any like leukocytosis, bloody stools, nothing that is more common or typically seen in like those organic structural gastrointestinal disorders. And then, of course, at this time, observing any psychosocial distresses that the patient may be wearing at that appointment. So, differential diagnoses. IBS is frequently associated with anxiety and depression, so it is important to assess those psychosocial influences because they can either be concurring or they can be subclinical. Patients experiencing IBS must also be considered for other organic gastrointestinal disorders, especially if they're experiencing that epigastric pain. You want to rule out biliary tract pain, ulcerative colitis. That may be associated with that type of pain, Crohn's disease, or even malignancies of the stomach, pancreas, liver, gluten, celiac disease versus those functional upper GI disorders, even medication-induced altered bowel motility, endocrine disorders. These are all really important to consider as well. It is important to remember, though, that nutritional deficiencies can be caused by any of these different pathologies due to malabsorption, which can cause zinc deficiencies, vitamin D deficiencies, or folate deficiencies, all of which are also correlated with psychosocial symptoms such as depression. IBS lab work and diagnostic workups, it requires a positive diagnostic approach rather than one of exclusion. There's no definitive evidence at this point to show that there is any type of testing that is highly specific for IBS. Rather, the diagnosis is specifically dependent on a comprehensive history and physical assessment. So the clinician must refer to that patient's subjective and objective assessment. Lab testing may include a CBC, an ESR, thyroid panel, or BMP. This way, the clinician can review electrolytes, any anemic processes, overall organ function, or systemic inflammation. Serum amylase, stool samples to, assess any ovas or parasites. But again, these wouldn't be necessarily related to an IBS diagnosis. So we really want to prevent further workup if it's not necessary, because that can, of course, be costly. And truthfully, the evidence at this point suggests that that's unnecessary. A really low, minimally invasive, low-cost diagnostic tool could be used is an elimination diet, which is essentially when the patient eliminates food over a 3-phase trial. So the first 4 to 6 weeks, they restrict themselves, especially from those FODMAP foods that we talked about, and then slowly reintroduce them over the next 3 weeks' time to observe if there's any individual responses to these types of foods. So management is dependent on identifying the symptom patterns of IBS and then prioritizing the overall management of what these symptoms are. So that management of IBS is really focused on reducing triggers or any type of psychological triggers or any type of gastrointestinal triggers. And that really requires like an integrated approach of addressing both nutritional awareness and also psychosocial support and well-being. So diet and gut microbiome support is really important. So you want to address the gut microbiome imbalances. And this can look like that food elimination diet, whether that's a FODMAP diet, whether that's dairy specifically with lactose in it, caffeine, wheat, rye, barley. You can also encourage the patient to utilize a diet journal so that they can keep track of their to better identify and understand their intolerance patterns and the foods that are associated with it. Fiber is also shown to have a great influence on patients whether they're experiencing diarrhea or constipation. 25 to 30 grams of fiber a day can, over a slow introductory period, can be really, really helpful for patients, as well as, probiotics. Probiotics can modulate intestinal pain by reducing the permeability of the intestines and supporting overall gut motility, as well as having a profound influence on optimal brain functioning. Bowel support symptoms, I'm just talking fast because I'm running out of time here. So bowel support symptoms can look like antispasmodic agents, peppermint oil. All of these can help minimize pain by relaxing that smooth muscle in the colon. And then Supporting emotional well-being as well. I'm going to wrap this up because I'm running out of time, so please take a nice look at the slide.